All right, well, we're going to talk a little bit about coaching and teaching tools in surgery. The goals for today are basically to go over 7 immediate steps, how to become a better educator, which will help encompass becoming a better coach and how to give better feedback and teach in the OR. Mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, the great teacher inspires. If you would, please take a moment to consider, if I were truly an outstanding teacher in the operating room, I would consistently do something. And the converse, if I were a poor teacher, what would I avoid, or what would I avoid as an outstanding teacher? I think we've all had anecdotal experiences with excellent surgeons that have shaped and forged their career. Hopefully we can be those for our future mentees. So these are the 7 things we're going to cover today in specifics. So the Hippocratic Oath is interesting, right? Because it references that we will gladly share our knowledge as is mine with those who are to follow. But the problem is that historically surgeons have never been formally trained in how to educate others. It's just like, here you go, teach the next person. And yet there's an educational science behind it that is completely, available to us, which has not been explored. As a matter of fact, when we look at general surgery residents, the majority of them these days do a fellowship because they're not comfortable doing surgery yet. 1 in 3 fellows can do a lap chole well, according to general surgery program educators. So what are the stakes? Well, clearly, they're for patient care and their families. How well are they going to do if we do a good job teaching or not? Medical legal risk, institutional things, personal fulfillment. And if we don't set our own standards and become excellent educators, perhaps somebody else will do that on our behalf, and we may not like what that means. So step 1, perform a needs assessment. At the scrub sink, I'll routinely ask, what have you watched? What have you read for this case? How have you prepared? And I also like to ask, what's the worst thing you can do, and how can you avoid that? And if that worst thing happens, what steps are you going to take to address it? It's interesting, there's some research shows that learners are poor evaluators of their own performance. Those who are beginners tend to overestimate their ability, and those who are actually high performers underestimate their ability. And of course, this is a plug for VJSM. Dr. Yaffe heads this charge where we got to get surgical videos sent into the site here so that we can teach others through video. Surgical diaries. Every surgeon should have a diary where they write down the steps of the surgery, what they did wrong that day, what they learned, etc., key decision points, potential post-op complications with references. Next, as a surgeon, we need to optimize our learning environment and model ideal behavior. I have a picture of Hemingway's Death in the Afternoon in the corner. One of the things that Hemingway cherished, and is the theme in many of his books, is equanimity, right? Grace under pressure. And so when you have a complication in the OR, when things aren't going right, are you going to be the person that hands the football to the referee after you score a touchdown? You're the person that's going to jump up and down and go crazy. So we want to model the best behavior. Grace under pressure is what we need to have. Also, be grateful to your team and staff and model behavior that you would want to do. The BID teaching model is an interesting model that comes out of SIU School of Medicine in Illinois. Basically, it's very simple. You ask the learner before the case, what do you want to learn in this case? And then intraoperatively, you focus very specifically on that area, and then afterwards you debrief. A trick that I've used with my residents and fellows for many years now is I'll basically do a case with them, I'll spend the day with them in the OR, I'll say, send me an email with 3 things you learned today. And those 3 things they write are very surprising sometimes, because you think you did just a crazy case and they're going to mention something, but actually gives you a lot of insight as to what they're learning or what they're not learning. Typically, I'll reply back with an email of things for them to read to further facilitate things. Okay, so another thing that you need to do is change your intraoperative teaching technique. So you need to you alter your teaching script based on the learner. I have this picture here, so routinely I'll have a medical student, I'll say, what is this structure? And then they'll say urethra, and I'll say, no, what's the formal name? And then, of course, the answer is the inferior pinna cava, right? So that's a joke that I make in the operating room all the time, regardless of who the learner is for the first time, but I always do the same thing. But as a teacher, we need to change what we do. So if you have a learner, yes, you got to tell them each step. But if you've got a chief resident, most of the time, it's best just to say nothing, cross your arms, and take a step back. See what they're going to do. Because you have to change, learners learn at different rates and they have different needs, and so you have to change based on who you're teaching. What are other intraoperative techniques? Cueing and pointing. So a lot of times we make unconscious movements. The best examples with like lap cameras or robotics. If the staff is driving the camera, they will center the area of dissection every time, right? So you have to think about for advanced learners, maybe I shouldn't do that for them. Maybe somebody else should run the camera. We also cue and fade with our forceps, etc. And again, sometimes it's best to not do anything, is just stand there and see what happens. Another effective technique is to think out loud. When you're first doing surgery with learners, say, I am doing this step for this reason. And then when the resident's doing things, you should say, okay, before you do it, please tell me what you're doing and why. And that can sometimes prevent a catastrophe. So also, it's interesting about the learning model is that the more there's a proper amount of stress to learn. If there's no stress, if there's no stakes, people don't learn very much. If there's a medium amount of stress, that's maximal learning. And then when they're on tilt, if things are going crazy in the OR, you're yelling at them, it's very unlikely that the resident fellow or medical student is going to learn anything just because, you know, they're on tilt, as we say in the poker world. Now, let's move on to effective feedback. Feedback is an interactive process that helps modify behavior. It needs to be immediate, it needs to be accurate, and I've got some other specifics here. But when you ask residents, they all want feedback. It's often the worst thing that we do. Little or no feedback was reported in one survey, and 80% of the time. What is effective feedback? Well, you can see the column on the left and right respectively. One is the good one is the bad one. So it should be based on observation, not hearsay. You shouldn't say you're too shy to somebody. You should say focus on the behavior instead. Try to ask a question after a lecture. You want to try to be specific, not general, non-judgmental, etc. So in summary, feedback creates a respectful and supportive climate. You don't want to do this in front of their peers where they're going to be shamed. You want to find out how the learner perceives his own performance, his or her performance. So you should ask them, what did you learn today? How do you feel about this? How are you doing? Often you get some very strange answers. It should be balanced, focus on behaviors, and then set up goals. Typically, it's best to end with encouragement as well. All right, next, utilize technology. Like every other professional athlete and pretty much every other profession does, whether it's an airline pilot, we've got all these amazing resources with videos and all these kind of things. This is from the ISSM seminar done last week. Dr. Ghazi is talking about these remote glasses that can be used. On one of the panels, the blue hand is somebody in a different state pointing out where they want to make this incision on this model, okay? So we've got all this technology we can utilize, which we must incorporate into teaching. At Mayo, all our cases are now recorded, and we do video review of the cases afterward, which is incredibly helpful, reduce the amount of cases need to be done to get proficient. Also, a great teacher removes obstacles, okay? A basic learner needs to be told what to do, but a more advanced student, a more advanced learner, your job is to remove what's inhibiting them from learning, whether it's outside stressors or whatever it is. So this is called an outside-in teaching model in which we remove the impediments that is preventing our learners from progressing. Last but not least, I'd highly encourage you to look up Randall Stutman from Admired Leader Institute. There's some free online podcasts you can listen from this guy. This guy's a genius, and he focuses on specific behaviors that we can all do to optimize teaching and being great leaders. Two specific ones I'll go into is second-hand compliments. Here's a picture this morning that I took. If you tell somebody else is great or doing something well, it eventually gets back to them, and that's really well received. If you tell somebody directly, they're immediately thinking, okay, what are they going to ask me for next, right? So use second-hand compliments. Also, the proper feedback sandwich. If you're going to have the sandwich where you say good, bad, good, the good and the bad has to have the same amount of emphasis and duration. You can't just give a snippet and then a monologue about bad things and then another snippet. And then if you can make your students feel like you're their fans, that is the most ubiquitous motivator of humans if you're their fans and they have the support behind them. All right, that's all the time I have. There are the various steps, and I thank you for your attention.